Well, hello, Joep, and welcome to the OT podcast. How are you today?
I'm good, thank you. Thank you for inviting me onto the podcast. Privileged to be asked to speak about my experience as an OT.
You're very welcome. Do you want to kick off by giving an overview of your career history?
Yeah, of course. So both of my parents are in healthcare. Mum's an OT, dad's an ex-mental health nurse. And so they were very much guiding me towards a safe profession where there'd always be demand and need. So healthcare was the way to go. Um, it started back when I was in school. I did a placement in Sri Lanka, where my dad's from, and I looked at the difference between public and private hospitals to see where the disparity was, the difference in funds, how patient care differed. It was more so from a medical perspective, but it gave me quite a lot of insight as to how equity was a big issue globally in healthcare. And that's what really pulled me towards the NHS, right? The NHS is a healthcare system that isn't based on how much you can pay or remunerative measures. It's based on clinical need. If you need NHS, it's there for you, right? And so, having mum as an OT, I went for a an interview for uh, occupational therapy degree on South Bank University. Really liked it, and then my course commenced. My first placement was in hand therapy, and that really drew me in further. Like I really want to do this when I qualify. And it's okay if you don't really know where you want to be. Lots of people do rotations for a while and kind of feel out, physical health and mental health settings, or in pediatrics or community. There's so much scope that an OT can do. But I knew from that moment that hand therapy was for me. And so after qualification, I spent a good amount of time researching where offered a band five rotation hand therapy to kind of make sure that my career pathway was all aligned in that sense. And I found a rotation at Barts, and that rotation at Barts had a hands rotation. I asked the hiring manager and the lead, can I go straight into hands? I was really keen. And for very good reason, she said no. She said, do your rotations first, and then we'll see about getting you into hands. And initially, I was a little bit like, oh, but I really know where I want to be. Am I just wasting time by, doing the other rotations I know I don't want to do, but I can do? But it was a very good piece of advice and a very good push. I found that as a ward-based OT on all the people's unit and the medical wards, that actually I built a lot of skills in complex, case management, time management, had to build rapport with a lot of patients and families, and could manage and learn to manage quite a large caseload of individuals without getting too stressed out. And so when my time came, I moved into a hands rotation. And the pace in an outpatient setting for an occupational therapist is something that a ward-based occupational therapist may not be accustomed to. They might be quite shocked. What do you mean you've got half an hour of a patient and then we're moving on to the next? You're doing, rapid assessment, you're doing, treatments, you're doing your notes, you're doing any kind of signposting and onwards referrals, and you're doing that all over again pretty much all day long. And so having the background of ward-based work really helped kind of get you in the right mindset and giving you the skills to survive in outpatients.
And
And
what,
so,
sorry, go on.
tell me.
No, what was it that drew you to hand therapy specifically?
I think I think people, right? I had a really good team as a student. People were really kind. They were really open. They were really willing to teach and really willing to give me that insight as to what hand therapy entailed and that opportunity to actually see myself working as a therapist there was one of those things that actually I'll never forget. And I really maintain as an educator or as a clinical supervisor for students these days. I really want to make sure that I give them a full scope of hand therapy, all the opportunities to practice safely, and really feel out if it's something they like to do. Some people know, some people say no, it's not for me, but I've tried it and really appreciate the opportunity. But that's completely fine. And I've given them yeah, the opportunity to kind of really try it out. And so I found that it was really key that I had that experience at every single placement so I could really not be tunnel visioned, but really focus as to what this entails, what the progression is like, really spending time with every member of the team. I'm not saying that other placements didn't offer me that opportunity, but having a good understanding of each made me kind of make a balanced decision as to where I wanted to be. And with hand therapy, I really liked and initially I was quite lost. Where is OT in hand therapy? It's a really biomechanical frame of reference where you're looking at, anatomy, clinical condition, and treating that. And at first, I didn't see it. But when you think about what the scope of OT is in hand therapy and later to come scar therapy, because that's a subspecialty within our department, there's really lots of opportunity to, you know, do occupational analysis, look at functional engagement, look at patient reported outcome measures to see where we could improve patient goals rather than our goals of, right, your total active motion is improved by X. Whereas that's not really meaningful to a patient. It might be, meaningful clinically in terms of looking at, is this a statistically significant change? But to a patient, that means nothing, right? They can either, carry on life as they used to. They can get back to their gardening or they can't. Yeah.
And was it the
So if I
hand therapy that brought you into the scar therapy? Was it?
exactly. So after completing a band 5 rotation, I applied for a band 6,
Mhm.
my own trust. And about 2, 3 years later, I applied for a band 7. And so currently I'm a 7 and have a lot of opportunity to kind of develop the role in the sense of scar therapy, in the sense of being a clinical academic. Um, and so the scar therapy department was historically managed by the senior team, but because of geographical reasons, the staff moved on, and so a spot became vacant in the team, the scar therapy team. And so I had a few months to shadow and upskill and learn because there aren't really a huge amount of courses for scar management. It's, I believe, quite a underdeveloped area within healthcare. I think people can identify and see a scar, but when it comes to clinically grading a scar or identifying whether a scar is immature or if it's clinically mature is a challenge to a lot of people and clinicians especially. And so as clinicians don't really know what to do about a scar, they don't really address the scar. And so I think part of my goals going forward are to, with any student, any new starter, any therapist that, has patients with scars, because in hand therapy, we see lots of post-op. So any post-op patient will have a scar. It's to really upskill them into, what to look out for, what the risk factors are, thinking about, interventions and modalities that can be multimodal to hand therapy, because scar management isn't just a single thing. It's most effective in a combination of treatments. And so I find that by upskilling the next generation of therapists, hopefully that will start the cascade of increasing awareness and knowledge as to what scar management is.
Thank you. So going back to the basics of scars. So can you talk about different types of scars, different grades of scars?
Yeah, of course. So a normal, in air quotes, scar is going to be one that's called a normotrophic scar. And that'll be a faint, usually like lighter pigment scar within the borders of the wound. It's relatively asymptomatic. And a key thing to note of all scars is managing patient expectation, right? A scar is a scar. It's a different formation or excess of collagen in the area. It's not going to completely disappear or fade. There'll always be a remnant there if you look hard enough, right? And so if you think about really young patients with more elastic tissue, they scar quite well in the future. You look at the scars, like, oh, really, that happened. I would not have been able to tell. But still, there usually will be a very slight remnant of a scar there. More excessive scars will include hypertrophic scars and keloid scars. And hypertrophic scars are scars which are still within the border of the wound. So let's say you've had an incision here. A hypertrophic scar will still stay within that line of the incision, but it will seem quite raised and almost bubbly. And that can carry quite a few symptoms, such as being quite itchy, quite painful, burning almost. Okay. And those hypertrophic scars are often very vascular, so very red, very raised, very bumpy. And if you think about how to clinically assess a scar, you're looking at Vancouver scar scales. Yeah, that's the most commonly used clinical outcome measure for scars. It's okay for measuring a hypertrophic scar because a hypertrophic scar is typically found in fairer skin types, Caucasian skin types. Okay, but less and less common in individuals with more melanin in their skin. Okay, and it's a scar scale that was initially validated for the Burns population as well. So it's quite good at picking up how clinically immature a hypertrophic scar is. But if we think about keloid scars, which are on the opposite end of the scale, they're scars again. Imagine we've got our linear wound that can develop more bulbous around that scar line, more raised, and they can keep growing without intervention. Okay. They're typically found in people of color, so darker skin types. And it's not great at clinically distinguishing maturity purely because like the Vancouver scar scale is looking at vascularity on fair skin. It's hard to see sometimes like how vascular a scar is on darker skin because when you're even palpating, the color change isn't massive, right? Because the melanin is masking a lot. And again, those scars can be quite disfiguring. If you think about the location of where those scars can be, they're usually in areas of high tension. So sternal, it can be across joints. So often, like for instance, a carpal tunnel release, you can get quite a nasty hypertrophic or keloid scar if you're, you know, prone or susceptible to scarring. Okay. And it can have a big impact on someone, mentally, physically, and also socially. And that's where OTs can really come into their realm of thinking, okay, tell me, how is this scar impacting your day to day? Think about an activity analysis. You can think about, occupational engagement, and you can think about performance in the area, right? It might just be that that scar is, you know, so disfiguring to that individual that they don't want to be out in public. They don't want to show that scar. They'll hide the scar. And it becomes especially tricky if you've got scars on the face or the hands, right? If you think about how functional the hands are, we're always using them, we're always in view. Okay. Same for the face, right? You can't go outside without someone really looking your face. And so it becomes a real challenge to, find a set of interventions for individuals that, work their routine to figure out how we can get them back into function and increase their occupational engagement. And so by building rapport with clients and patients, it really is key to understand them as a person, not understand them as their scar, which is, I think, what is lost as a junior therapist. You think quite bottom up, you think quite biomechanically, right? Whereas we should be seeing the person first. And that's where patient reported outcome measures really come into their element here. Because as I said, it's all well and good that a clinician is measuring how their scars are looking and how mature it is. But if we don't use patient reported outcome measures, how do we know how the scar is truly impacting them? What might be looking quite mature to you and me might be looking absolute 10 out of 10 worst case scenario for them that, just can't accept having. And so with scar management, you've got compression therapy, which is designed to flatten collagen and help, reduce the amount of blood flow in the area to reduce fibroblast activity. You've also got various acting mechanisms from that compression garment if it's measured tight enough. And that can be to increase the local temperature of the area. Yeah, which increases the activity of collagenase, an enzyme that breaks down collagen. But with compression garments, even though they are the gold standard, nobody really knows how they work, which is really interesting. After all these years, you'd think there would be a definite, yeah, compression garment works by doing this.
Mm.
But no, we know that it works somehow, but nobody really knows for definite, besides 100 different theories as to how it works. Next up, we've got silicone therapy. Okay. And that's probably the most marketed scar intervention out there. If you think about, I don't know where you were, Lorna, but on my tube, for instance, I can see ads for keto. I'm like, whoa, this is great. People are actually seeing silicone products for scars, right? And a silicone product is all there to reduce something called transepidermal water loss, which is water loss from the scar surface. I always describe it to my clients, my students, anyone speaking to who's interested about scars as collagen fibers being like this, where you can just about see me, right? Whereas a scar, the collagen fibers are far more disorganized. You have strands going here, strands going there, and that mesh is larger. Where that
Just
mesh is
because
larger, when
for the podcast people can't see you, so can you describe
sure.
what you're doing with your fingers?
Yeah, no, of course. So what I'm doing is I'm kind of aligning my fingers together,
Hmm.
and I'm almost interlocking them for normal collagen
Hmm.
in the skin, and for a scar, I'm making it a bit of a lattice, bit of a cherry pie web, right? And so where that lattice is where that moisture is escaping and evaporating, right? And what a silicone product does is it forms a bubble over the top to stop the moisture from escaping. Okay. But I find that even though these products are marketed, they're marketed almost for the wrong reasons. A scar silicone is commercially available, but it's marketed for cosmetic reasons rather than medical reasons. And I find that's really pushing scar management back
Hmm.
in the sense that when we ask GPs to prescribe silicone products, there's often quite a pushback in the sense of, it's a borderline substance, so we're probably not gonna prescribe it. And so it's hard for patients to access the products they need for a medical reason. It's the same for another intervention that we carry out, which is skin camouflage. And skin camouflage is paramedical makeup.
Hmm.
It's a prerequisite to have when you have a burn center or when you're working at a burn center, it's a prerequisite that at least one member of the team is trained in paramedical makeup. Okay. But I know that they had to fight to actually get that on the BNF, and it's still a borderline prescription, right?
Mm.
So some GPs will really push back and fight about not prescribing it. And again, we've got to be pragmatic. It's the NHS, there's cost, but when there's clinical needs, it's truly an essential if it makes a difference to individuals and their lives and their engagement
Mm.
with occupation and even their productivity, their leisure, their self-care, thinking about everything that that person is. They're a functional being, right? Okay, next up we have different modalities of massage. Okay, so you've got your general root scar massage post-operatively is typically using a nice thick cream. So the thicker the better, but not as thick as a cocoa butter because it will penetrate through the layers of the collagen. And just doing your root circular massage. So I've just got my thumb on the screen. I'm just rolling circle, 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 circle down that scar line. Okay. Now a lot of people think that scar massage is just that, right? But if we think about that scar, we're thinking about all those layers of collagen that are almost clumped together by the glue that is the scar. And so what you really want to be doing is also doing a very light type of massage where you're lifting the edges to improve that flow of tissue, improve the
Mm.
flow of fluids beneath the surface. And a really useful training that I completed was one called Scarworks massage. And I carried out that training following patient feedback. So there was a colleague of mine who was completing a master's in looking at how our service was running, our SCAR service running as part of it. And she identified that the patients wanted a more hands-on service, that they found that the service is very prescriptive. We give silicone, we give advice, and off you go.
Mm.
But since I've joined and I run the department, what we do is we coach patients, we teach patients into all the techniques as to multimodal scar management. And so I teach them techniques for ScarWorks massage. And if they have the means to, if they want to, I look at a ScarWorks register and I select a therapist and I say, find someone who's local to you, try a few sessions out, see what you think. And patients generally have really good feedback for that. And I don't think it's only about the physical intervention itself. I think it's about the whole self-care, right?
Mm.
A patient's going for intervention to look after their scars, to nurture their scars, to be at one with their scars, to be more accepting of their scars, to take an active role in their treatment rather than come to clinic, get given some products, probably don't use the products, and then come back in a few months to say, hey, nothing's really happened or nothing's really changed.
Mm.
And so in clinic, I think that finding the right routine for each individual is so key. And that's where OTs can come into it, right? Because we have a really good understanding of that person, that almost that biopsychosocial model. What makes that individual an individual? What makes them unique? What makes them a functional being? And asking all those questions and delving deep into a particularly challenging part of their day to day, if it may be occupation focused, and really breaking it down with them. So doing activity analysis and looking at the components, the functional domains of what they're doing can help, right? Because we don't just talk about the scar, we think about physical movement, we think about compensatory, equipment, we think about adaptations that can be made to increase engagement in that domain. And that's why OT isn't lost. We really have that to kind of draw from, and it's a really good skill in our toolkit to bring forward to help that patient out as part of that multimodal intervention.
Mm.
And so we also coach patients as to which products to use and how to use them. So if I just lean back into the silicon therapy for a moment, people say, "Oh yeah, so I've been proactive. I've seen this ad. I've bought it." I'm like, "Absolutely amazing. I love that. You've actually, looked what's available. You've tried it out. Here you are today, really keen and engaged for active intervention, not passive intervention." But unfortunately, the advice just isn't there as to how much to use, how to apply, how frequently. And, with scar management, I find it's a very precise and targeted intervention. You use the wrong cream, it won't work.
Mm.
Right? You use too much silicone, it won't work. You're not consistent. You think that, okay, I missed out 3 days. I'm just going to put 3 times as much on. It won't work. And so I find that there still needs to be someone to provide that advice, to provide that guidance,
Mm.
even though it might be in the patient literature, that little leaflet that comes into any medications. But you think about how many people actually look at all that and read that fine print that's about this long.
Mm.
Yeah. And so that's why scar management is helpful, and it's really key for OTs to lead on.
And while we're talking about the different techniques that you use,
Sure.
there's also something called kinesiology taping. Is that something that you do?
Yeah, so K-taping is something that I do a little bit less frequently now.
Hmm.
Um, and it's a very valuable tool to have, but you got to find the right patient for it again.
Hmm.
And I find that K-taping is good for postural alignment. So let's say that someone's overcompensating with a certain set of muscle groups because that scar is putting a lot of stress through one area, so the body isn't loading through it. Okay. Um, and K-tape is good to kind of realign, to give a bit of a physical prompt that, oh, I'm slouching again. That tape is going to pull me back up, and it's going to keep me in a good posture, a good movement pattern.
Mm.
And the issue that I find it challenging is that a patient has to apply it themselves every few days for it to be effective, right? I can apply in clinic, but they're not going to come back to see me in, 2, 3 weeks. Unfortunately, being as pragmatic as possible, that K-tape isn't the best option.
Mm.
And I'd rather teach a patient a set of exercises that's going to strengthen that muscle area, really make them aware that actually they are slouching, they are overcompensating, because that will give them more of an active pull. In private practice, however, I would use K-tape a little bit more because I'm seeing that patient more frequently because I'm afforded that opportunity to do so. And that's where I think there's a bit of a difference between public and private. Like we can afford to allow the patient to be a little bit more passive, which is probably not the best thing ever, but we can continually guide that patient through their journey and ensure that their interventions are as effective as possible. Whereas in an NHS consultation, you've got probably an hour or half an hour every couple of months, and you just really have to make sure that patient walks home with good patient information. They know
Mm.
where to seek you out if they're struggling. So I always give our email address out after every consultation. So if you need us, we're here. That's what it's there for. Email me. I'll give you a call. I want to know. I don't want to see you in 3 months and think, what have you been doing? I wasn't sure. Sorry. I've just come in today because I wasn't sure as well. So can you tell me again? I was like, oh, use the email next time. Tell me. Because, you have a bit of a golden window for scars. So scars can be impacted best within 2 years, right?
Hmm.
Anything over then, you can still impact a scar, don't get me wrong, but the journey becomes a lot slower, a lot harder. And it's something that the NHS website cites. It cites that scars mature in 2 years. It's very general advice. It's very direct and to the point. But actually, if you think about excessive scars, such as the ones I've spoken about, the hypertrophic and the keloid scars, if they're left to their own devices and management isn't the best.
Hmm.
So, like I said, the symptoms, lots of itching. If people keep
Mm.
itching their scars, you're prolonging that inflammatory phase. You're increasing how much collagen is getting deposited in the area. And that scar potentially going to grow. It's going to stay symptomatic for longer.
Mm.
And so it's really key that, people don't have those expectations. Oh, it'll be fine. It's all about how you manage it, how active you are in your intervention. And that's way you'll kind of really progress on.
Mm.
Sorry, a bit of a cold, so I'm just blowing my nose. So if anyone had headphones on there, I apologize.
It's okay. You've mentioned so there's an excess of collagen with the scars and
Yeah.
that they
Yeah.
can keep growing. Are you able to talk more about what's happening medically when a wound turns into a scar and are the different stages of healing in that process?
Yeah, of course. The key is all in the remodeling phase of wound healing. So if you're thinking about how collagen gets deposited in an area, so imagine that those two arrows, that cycle. So collagen gets deposited and
Hmm.
collagen gets remodeled. Yeah. There's often an imbalance between how much collagen is
Hmm.
deposited, and how much is remodeled. And often with excessive scars, you have an excess of deposition where that collagen keeps getting pumped into that area, pumped into that area, pumped into that area, and not as much gets remodeled. And it does differ a little bit depending on your hypertrophy, your keloid scars, but that's relatively the crux of things. And big risk factors for excessive scarring are chronic wounds, right? If you've got a wound that's been open for a long time, that your body is struggling to fill it with collagen. It's pumping, it's pumping, it's pumping, but it's not quite filling the area. So that might be because of comorbidities, like a poorly controlled diabetic, thyroid issues, hormonal imbalances. It might be because of infection. It might be because of recurrent surgeries, again, washouts due to infection, or let's say it's insertion and removal of metalwork through the same scar area. And it might also be genetically predisposition to excessive scarring. So we know that people with, like I said, darker skin types and more melanin in their skin, and with hereditary prevalence to keloid scarring are about 70 to 80% more likely to get them. And so it's about how someone scars. Another risk factor is where the scar is. So if the scar is in a location where there is quite a lot of tension running through the body. So for any listeners or viewers are interested, have a look into Langer's lines. And Langer's lines is basically a diagram which talks and shows tension lines running and flowing through a person's body. And if you have a wound or you have a surgery which is perpendicular to a Langer's line, you're likely going to have a lot of tension running through that area, and that's going to prolong the healing. That's why you see keloids in quite central sternal areas. You see them across joints because that tension is constantly flowing. And it's not like we're going to say, right, to minimize the risk of you keloiding, we're going to strap your arms together and hope you don't move. Because pragmatically, that won't work, will it? You still have to allow someone to, be functional.
Mm.
And so as a result of that, that tension running through the area is a problem. But if we're proactive about things and we know that there's going to be a lot of tension running through an area that's at high risk, we can again use K-tape to tension shield the area. So we can put a diamond around the scar
Hmm.
to ensure that, we're adding resistance and shielding that scar so that the tension flows around it rather than through it.
Thank you. Um,
Okay.
and you've touched already on how scars heal differently on children compared to older adults. Are you able to talk a bit more about that?
Yeah, of course, of course. So it's about elasticity in the tissue and the collagen fibers. It's more elasticity in kids and fetal tissue. And I think that they're doing quite a few studies on scarless healing in fetal tissue. Um, I had a really good published case report as a co-author in the British Medical Journal case reports of a neonate who developed necrotizing fasciitis. And so he was blue lighted to a few different hospitals and had quite a large surgery, which is pointing to my neck here, quite a large surface area. And we always thought that he'd need a second surgery to kind of release that scar because it'd be so tight and constricting. But we have really achieved a good outcome with his case. He's now got full range of motion, no need for a second surgery. The scar is quite quickly matured within a timeline of about, I believe it was around a year. And functionally, it's not limiting him or his development. And so at Tommy's where I am now, I run a pediatric clinic for half a day a fortnight. And in that clinic, I get referred any types of problematic scarring that the nurses want a second opinion on, or want me to manage with a compression garment or a little bit more intense intervention. And so I think with pediatric scars, it's really important that we get them mature as quick as possible,
Mhm.
because the last thing that we want is we want it to cause a joint contracture or restriction in their development or growth,
Mm.
or a developmental milestone being missed because of a scar. And so the advice for pediatric scars differs a little bit, right? We think about different products we use, but we also have to consider the parent. Can a parent assist in applying these products? How consistent will they be? And it might be choosing a type of silicone to determining the amount of time a scar is massaged for and how a scar is massaged. Kids are often quite wiggly. They'll say it's very, very painful when actually it's just a bit sensitive. And so really coaching parents and kind of teaching them as well as to, what a scar is, and, managing their expectations is really key to outcome. And even if a scar is mature for a pediatric patient, the advice is to continue to moisturize the scar, because
Mm.
generally across the board, any scar at its healthiest will be about 70% as functional as normal skin. Right. And if you think about everything that the skin does, so that UV protection, that moisture retention, all those sensory potentials, right? A scar at its healthiest will be about 70%. So as long as people know that, then they're like, okay, right, we're close to optimizing this scar, because we want to keep it in this condition and ensure it doesn't reactivate when my kid has the growth spurt. We're going to be quite consistent with just moisturizing that daily, just
Mm.
to be careful and mindful of it. And so you're topping it up here and there to stop the scar from drying out, to stop it from causing an issue, right? And then when the kid's older, they can do it themselves, right?
Is it important to keep the scars out of the sun then? You mentioned the impacting the UV um,
Yeah,
quality for
exactly.
the skin.
Because of the melanin difference in scar tissue is a lot more likely to burn. So
Mm.
even in those darker skin types as Fitzpatrick, end of scale 5/6s, who usually wouldn't even bother with SPF,
Mm.
the scars will need it. Yeah, purely because they're more susceptible to burning.
Mm.
If a scar burns, then you've got a cascade of that inflammatory cycle and a few more issues in that sense.
And
Yeah.
what's the role of steroids with healing of scars? How does that help?
Yeah, so steroid injection works in two ways, usually. First of which is to reduce any local inflammation in that area. Okay. And that makes it a little bit more, what's the word? A little bit more susceptible to scar management in between, right? You reduce a steroid injection, the inflammation reduces, and then you can put your silicones and your creams on there and massage and massage, massage. And that way you can really impact the scar a bit better between those episodes. The second acting mechanism for a steroid injection is it makes the collagen water soluble. So by making the collagen water soluble, it makes the collagen almost be absorbed by the body. So it can get a bit flatter, as well
Mhm.
as the inflammation reducing, it can get a bit flatter. Um, Again, steroid injections should be, are completed by plastics doctors at present, working on a bit of a long-term vision of being able to do them myself.
Mm.
But I think there's quite a lot of governance for OTs to be able to inject. I know that physios have got it a bit easier,
Mm.
but with OTs, it's a little bit more challenging. And these steroid injections are usually about 8 to 10 weeks apart to be most effective. Yeah.
Thank you. And lifestyle factors, things like hydration, nutrition, exercise, sleep, do these have an impact
Yeah.
on scars healing?
I think it's really important that, again, lifestyle factors such as stress
Hmm.
are well managed. So there's a big link, and there was a study recently completed about how an excess of stress hormones resulted in increased keloid growth.
Mm.
So, which is really interesting, right? It's just why, as OTs, we need to address all three elements. We need to address that physical, that social, and that mental health component of things. And so, if I have a new patient in clinic, I always carry out part of the McMaster scar cue. There's a psychosocial scale. And I find that a lot of these patient-reported outcome measures, even clinical scales, don't really address the mental health perspective, um, potentially because of previous stigma attached to it. Like, oh, you asked about mental health now, what are you going to do? Are you going to put a mark on my file? Are you going to say
Mm.
that I have or mental health. And you're wrong, like it's a very intimate thing to talk about, right? With a person that you've never met before. Like, how's your mental health?
Mm.
Some people will open up. Actually, like I didn't know you were gonna ask me that question, but actually, I'm struggling a little bit.
Yeah.
I'm really stressed out about other factors in my life, not just my scar. I've got X, this, that going on, and I'm not managing well. And then, right, okay, really thank you for sharing that with me. There's some services available with your GP on referral, such as talking therapies. Would you like me to signpost you? They'll say yes, they'll say no, they'll say what else is that out there? They'll say there's waiting lists, they'll say yes, that's how the NHS is. And
Mm.
then if they have the resource to, then I'll direct them to apps such as Better Health, where they can choose their own therapist, etc.
Mm.
Yeah. And I think having a good understanding of the current landscape as to, who's out there, public and private, has really increased since the start of my time. I have a good network of individuals refer to or lean on, ask for. Um, and so stress is a really big factor.
Mm.
I think when it comes to sleep, it's time to repair, right? So sleep's important. And it comes to your nutrition and hydration, a well-balanced diet, lots of hydration, always key
Mm.
for any types of healing. And usually when it comes to the healing stages, I think there's a few studies that have had some conflicting news recently about um, increasing amount of protein. Like some studies say yay, some studies say actually it doesn't really change much. So I always say just a balanced diet,
Yeah.
make sure that, if you can, find an anti-inflammatory diet. Yeah, because that might impact your scars.
Hmm.
Um, but yeah, I would give.